You are listening to Medscape's In Discussion series on breast cancer and HER2, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Kathy Miller, Valve Lentero Professor at the Indiana University School of Medicine, Department of Medicine, Hematology Oncology Division. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Hi, everyone. I'm Dr. Kathy Miller. Welcome to the Medscape In Discussion podcast series on breast cancer and HER2. Today, we are going to tackle the management of patients with HER2-positive oligometastatic disease. Now, this is an area that I think we all struggle with, particularly if patients are getting staging scans that you might not otherwise have done. You find a single bone lesion, a small liver lesion. You kind of wish you hadn't done the scans, but now you're stuck trying to figure out what to do with this patient. So joining me today to tackle this and other problems of those patients with oligometastatic disease is Dr. Heather Parsons. Dr. Parsons is a medical oncologist at the Dana-Farber Cancer Institute and assistant professor of medicine at the Harvard Medical School. Her research has focused on the use of blood-based biomarkers to develop better tools for directing existing treatments, to avoid over-treatment, and to develop new treatments to improve the lives of our patients with breast cancer. Heather, welcome to Medscape In Discussion.
Thanks so much. I'm happy to be here.
I'm going to give you the first difficult question. What is oligometastatic disease?
So oligometastatic disease, we wish we could look this up in the dictionary and find it, but there's no definition exactly there. When we look back at studies that have been done and when that has been defined and see that it can be anywhere from one site of metastatic disease up to generally 5 sites of metastatic disease, and even in some other studies, even more than that, and sometimes with some qualifying definitions about what those sites of disease are, where they are, how accessible they are to local therapy. It makes challenging studies because of that.
It is. And I think one question that comes up is a patient stage 4 at diagnosis? We'll assume that that's the group we're talking about. Are the patients with oligometastatic disease really different than the patients who have more lesions, more widespread metastatic disease?
I think we don't know the answer to that. There is some thought originally that they weren't so different. But as you think about the extent of disease in somebody who has widely metastatic disease and also what heterogeneity might be there, and it makes it more potentially difficult to treat, there probably is something different about how well they do. And we know that based on retrospective studies that is the case, that patients who have oligometastatic disease do better, both in terms of how well they do on the first therapy, but also how long they live. And this makes us think that we should be treating them in a different way, that one size doesn't fit all in terms of how we approach oligometastatic versus widely metastatic disease.
When we think about broad strokes, it's perhaps not surprising that patients in whom you see more disease on scans don't do as well as patients in whom you see less disease on scans. And as our imaging techniques and ability to detect smaller and smaller amounts of disease continues to improve, this may be a group that we encounter more frequently than we have over the last decade or two.
I mean, it makes sense when we think about our staging system for early stage breast cancer that includes, from an anatomic perspective, smaller cancers. Patients with smaller cancers do better than patients with bigger cancers or cancers with lymph node involvement. And so you might extrapolate that to the metastatic setting where patients with fewer metastatic lesions and less burden of disease will do better than patients who have more extensive disease. And for sure, as we do more sensitive staging scans, we will find more of these, and we do find more of these.
So when we talk about patients with oligometastatic disease doing differently than the global population of patients with stage 4 disease, I think what people are really talking about is thinking or wondering, are some of those patients curable? And should I be approaching their therapy with curative intent? How do you deal with that question with the patients with oligometastatic disease who find themselves in your exam room?
It's a tricky one. I think we have this very binary mindset of early stage breast cancer being curable, meaning stage 1 through 3, and metastatic or stage 4 cancer being incurable. And I think some of that comes from our terrible experience. I wasn't part of this, but in the late 90s, thinking about stem cell transplants in patients with metastatic breast cancer. But there is something different about oligometastatic disease, and it's a tough conversation to have with a patient because you don't know the answer and you don't want to overpromise to say that, yes, you have something that might be indeed curable, but you also know that there is something different about that patient with fewer metastatic lesions. And there are no guidelines. There is no clear path in terms of what to do with a patient like that, and also what conversation to have with them. I usually can say, be more optimistic, but to try to avoid overpromising. It's a fine line to walk for sure.
The challenge in those discussions is it could be a very big difference in treatment and potentially a big difference in the toxicity of treatment and in the more immediate impact on a patient's quality of life. In reality, when we treat people with adjuvant therapy or neoadjuvant therapy, we're treating metastatic disease. It's just disease that might be there that we can't see. So this is perhaps those patients who've just put a toe over the line with something we can see. So it's understandable to think it's such a small amount. Maybe this is curable. But that could mean really big differences in the systemic therapy, but also questions of, do you proceed with surgical resection of the primary? What about radiation to the breast or the chest wall? What about surgery or ablative therapies to those sites of metastatic disease? That's a lot of decisions to face with a patient who's newly diagnosed.
It absolutely is. And each of those decisions we have no guidance for, right? We don't have a clear algorithm for how to deal with somebody who has newly diagnosed oligometastatic HER2 positive breast cancer. And so it makes the conversations even more difficult on each decision point.
Let's take those decisions one at a time, because we do have some clinical trials that have tried to address these. So first, for the patient who was found to have metastatic disease before they've had surgery for their primary, realizing some of these folks may be identified because their primary surgery identified a greater amount of lymph node involvement than was initially suspected, and that led to staging. They've already had surgery. But for those patients who've not had surgery, should they have surgery? Does that improve outcome for them?
So the retrospective studies overall looked like if you do primary surgery on a patient who has metastatic breast cancer, they were very promising initially. There's a lot of enthusiasm around this, but then when we looked at the prospective studies, there's a bit more of a mixed result. And the ECOG study that looked at the use of primary surgery for patients with a metastatic breast cancer, unfortunately, showed that there wasn't a benefit for primary surgery. But the argument against that is that those patients had mixed subtypes of breast cancer. They didn't all have HER2 positive breast cancer, and there are other challenges that make that study difficult to interpret. But overall, if we're looking and we're being strictly evidence-based, when we think about the studies, there's overall points away from doing primary surgery for patients with metastatic breast cancer. I will say that that's not necessarily always the case, and we do different things with different patients. But if we're being very strict about it, that's really probably the answer right now.
So one thing that I think they got right with the ECOG study is patients were not randomized to surgery or not immediately. They all had a period of time on what they and their oncologist thought was the most appropriate systemic therapy. And only those patients whose disease was stable or responding were then eligible to be randomized. Well, I think they got that right. That study has been criticized for the way that was put into practice. The systemic therapy was not mandated. So for patients with ER-positive disease, some of them may have just been on hormone therapy, and that's not the full aggressive therapy that you would have given them if they were being treated in a high-risk adjuvant situation, for example. And I think it's a little hard to argue that somebody whose disease is just stable to whatever I think is their best systemic therapy is still going to be curable. It seems to me like we should really hone in on the patients who have a really dramatic response to that systemic therapy.
I agree. And I think in HER2 positive breast cancer, it's much easier to do that because we know that the responses to first line treatment can be so dramatic, and to expect that is reasonable for somebody who you're going to consider doing curative intent local therapy that's not without side effects, to use that as a metric to decide on whether to go with local therapy.
So the other question that comes up a lot is, should there be any therapy to sites of metastatic disease, not driven by symptoms, but radiation of bone metastasis that are causing no symptoms, or stereotactic radiation to the remaining lung lesion, or even surgical resection of some of those lesions? It becomes both a difficult conversation and one where we need to be careful that we're not putting patients in the middle of a squabble between their medical oncologist and their radiation oncologist, who might be saying, I could do that really easily and with 5 fractions and minimal toxicity, and why would you not? Why would you not do that?
Right. We definitely want to avoid putting patients in that situation. And then when we look at the data for doing that, it becomes a similar situation where it's challenging to figure out what the right answer is, because the best study that we have in breast cancer is probably the NRG study. And when we look at that and see that there was no benefit for doing local therapy for patients with oligo-metastatic disease in terms of radiation therapy. But again, the argument against that study in this particular situation in HER2 positive breast cancer is that it isn't exactly this population. There is a study that is in discussion in the TBCRC, which is thinking about doing radiation for patients who have had response to their HER2-directed systemic therapies with oligometastatic disease. And I mean, it's early in discussion, but it'll be interesting to see what that would show if it happens.
Yeah, and I think it's particularly important that we're honing in on the HER2 positive patients for this discussion, because that certainly is the subtype of disease where there's been the greatest improvements in the efficacy of systemic therapy that we have to offer patients over the last decade. And I think that makes it hard not to wonder if for some of those patients who have enough disease that we can see, but have not been exposed to any therapy, if their disease still might be curable.
Absolutely. I think we should be wondering. It's on dogma to say that it's not curable just because it is a certain way, when we know that our therapies have changed over time. They've gotten much better, particularly in this space, as you say, and where we have tools potentially that could leave somebody without disease and with a long life expectancy, and they might be able to leave this behind.
So the other question that comes up, particularly in HER2 positive disease and oligomet, is, suppose you and the patient over a series of conversations have agreed to embark on curative therapy. She's had an excellent response, so you've proceeded with the local therapies to the primary and the sites of distant disease, even if you did so acknowledging some uncertainty as to whether it was adding benefit to her therapy. The other question that's about to hit you is, how long does she continue the HER2 targeted therapy?
I think, as we were talking about before, this is an interesting one because we're quick to jump to the local therapy. And maybe that's because they're short term, but we are also slow to, in my experience, consider stopping the systemic therapy. Maybe it's a little bit scarier. We know how effective it is, and the thought of stopping it seems scarier. But I think if we're having these conversations with patients, we should also be thinking about the systemic therapy and what the right duration is. We have some case series that show that some patients do stop and that those patients can do well, but we don't have any prospective studies looking at that. We're doing one right now to look at stopping treatment for patients who've had exceptional response, but we don't have the data yet. This conversation is often the hardest. We know these treatments are also not without toxicity. They're certainly not our most toxic treatments, but they do require patients to come in every 3 weeks to clinic. They're expensive. They do have side effects for people. And so it's an important question to consider with patients.
I think there's also the challenge of worrying if you stop that you will have caused harm. Because if this was somebody with more extensive metastatic disease, we know from several studies that continuing HER2 targeted therapy of some sort, not just until progression, but beyond progression, improves overall survival. So The challenge is for the patients who may have been cured. They're on HER2 targeted therapy for way longer than they need. But for the patients who are not cured, stopping could potentially be harmful and could potentially shorten their survival.
And we don't know whether if you restart, so in that patient who potentially you stopped and the disease recurs or shows itself again, whether restarting that therapy gives you the same benefit as continuing the therapy would have given you. It's an important question we don't know the answer to. And we don't have a marker right now besides scans, which we know are insensitive, and a billion cells is a square centimeter on a scan. We don't know yet whether any of our other potentially more sensitive markers could guide those decisions. And there's a lot of excitement in that space, but we don't have an answer yet. I'm excited to see where it goes.
So I want to ask you about some of your work in looking at those potential circulating biomarkers, because this is something that keeps me up at night. Early in my career, a couple of times a year, I would be referred someone from the community for a second opinion because they had had a circulating tumor marker, whether it was CEA or a CA15-3 or 27-29, that was above normal. And it had been repeated a couple of times, and it was above normal. And they had been scanned every which way they could possibly be scanned and found nothing. And the question was always what to do with them. And my advice was always to stop doing the tumor markers because they just weren't helpful and were causing all of this angst and harm. I do wonder if I am about to see a similar deluge of such patients just with different tests.
Yeah, and I think that's a big worry with the tests that we have right now. The most commonly referred to circulating biomarkers right now are ctDNA, the circulating tumor DNA, which are the tiny pieces of DNA that gets out into the bloodstream, secreted or released by cancer. And the difference between those tests and the tests we've used forever is not everything, but they are more specific and more sensitive, especially if we're using a ctDNA test that's designed for detection of this minimal residual disease or molecular residual disease, however you want to refer to it. They are designed typically by a patient-specific fingerprint that identifies the tumor that was present in that patient's body when they were diagnosed. And so you can use that fingerprint to then look for these tiny bits of cancer and identify them potentially sooner than you identify disease that has recurred and is visible on scans. But what we don't know yet is we don't know whether that is meaningful. So it's interesting, and patients are very interested in having these tests.
It's almost a whole other category of oligo-metastatic disease. It's just oligo-metastatic disease that I think I detect on a blood test that I don't see on a scan. Some people would throw circulating tumor cells into that as well, but it has the same problem.
Right. And if we don't know, I think the next step that we need to take, which we haven't done yet, and we should do this before we start using these tests widely, which is my worry right now because they are available and patients are asking for and doctors are ordering them, is we need to ask, does that make a difference? So if we treat this MRD with effective therapies, and that's another important piece of it, we need effective drugs to use to treat this. Does it improve how patients do? Does it improve how long they live? Does it improve their symptoms? And if the answer is no, then we need to not be using these tests in our patients. I am a little worried that those are coming so quickly into clinic that we are going to be facing them, as you say, without answers to those questions. But I'm also hopeful that those studies are being designed, and some are even ongoing right now, to be able to answer that question.
It's a real challenge for developing those surveillance tools, whether they be imaging or blood-based surveillance mechanisms, because the success or the clinical utility of them is partly related to how sensitive the test is. But it's also intimately related with what effective therapies do I have to offer? And are those therapies more effective if I use them sooner, however much sooner the test might be? I have to say I worry that our testing ability has improved faster than our treatment ability. They're so linked.
I think it's very context dependent. I hope that HER2 positive breast cancer is actually one of the places where this is going to be most impactful because we have highly effective therapies. And if we have these highly sensitive diagnostics, maybe that pair is going to make a difference for patients. I am hopeful and somewhat optimistic that that might be the case. But I think in other situations, potentially, these are being investigated in post-neoadjuvant triple-negative breast cancer where there's residual disease. That's a trickier problem. I mean, that's a place where if you detect something, it may be there, it may be real, but what are you going to do with that? And how are you going to make a difference? That's a different problem.
Well, Dr. Parsons, thank you so much for joining me today. This is a problem that I think we will all continue to face, and we'll hear more about those patients with oligo-metastatic disease, whether found by imaging at diagnosis or found by surveillance blood tests. This is definitely one where the approach to patients evolves over time and may include an initial decision to proceed with curative therapy, realizing that if patients don't have a really robust response, the goals of therapy probably need to change. And that may have implications for whether additional local therapy to the primary or sites of metastatic disease still makes sense for that patient. And for those patients who do really well, we will continue to talk with them and you as your research evolves about how long patients should continue treatment. Unfortunately, there's no simple answers to these questions. Thank you, our audience, for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on breast cancer and HER2. This is Dr. Kathy Miller for the Medscape In Discussion podcast.
Thanks for listening to Medscape's In Discussion Breast Cancer and HER2 podcast series with our host, Dr. Kathy Miller. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on breast cancer and HER2.